Okay, well, I've been at this for a while and kind of used about every possible strategy to help these poor people with this back pain. This back pain is just awful for people. It devastates their lives, their families, and the surgical techniques that were being used were good, but not good enough. And so it's been a constant search for trying to develop a procedure that could adequately address the issues. I came upon the Cayman's Triangle through the endoscopic things, which Tony Young introduced me to. Tony Young was very adamant that he would never do a fusion, that he could do everything through endoscopic. He certainly could do a lot through endoscopic, but eventually I convinced him to do a spinal fusion through Cayman's Triangle, and I think he, at the end, joined up with us in that endeavor. But the first one was done actually back in 2010. So I've been working through Cayman's Triangle now for about 14, 15 years. And right now it's the mainstay of my practice. About 80% of the spine work that I do is outpatient, and we take all comers. There's very little circumstance in which Cayman Triangle can't be used if a person is attempting to do an interbody fusion. It can be done very safely. I think it's been kind of shut out, and it's still kind of like a new thing because I think there's a lot of pressures from the big companies and a lot of the money people in the industry that are looking for profit margins, and Cayman, the work through Cayman's Triangle can be done pretty cheaply, inexpensively, and really hasn't taken hold because of that. But the first case was done when I had a patient who he had what was called an Optimesh bag back in 2010, which was the so-called bag of bones. It was a mesh bag that was placed through Cayman's Triangle. And the patient came to me just incapacitated with pain. Apparently there was a reaction of the Optimesh bag to the end plate and maybe a little bit of stress in the neuroforamen, and had been to several surgeons who recommended an OLLIF or translaminar decompression to revise that. And I looked at the back and thought, there was a pretty wide open inner space, and it looked to me like a little bit of a slip. So I thought there was more room in the Cayman's Triangle. So I thought we could attempt to take the bag out just through the approach they used to put it in. So simply made an incision, and within 5 minutes, the whole bag came out with the pituitary rongeur, which was really quite amazing because there's quite a bit of pathway there. And it just was fortuitous that the case before that I had worked with a startup company who was showing me a new tapered bull shark cage, pliff cage, that I'd used in the case before. So I thought, well, why can't we just put, with this bag came out, let's put some bone, decorticate a little bit more, and put the peak interbody cage in. So I did that and did it through Cayman's Triangle. The patient was amazing. Instantly, the pain was completely gone and remained that way. So the outcome was phenomenal. It was a 15-minute procedure. And the engineer, who was also at that point also showing me the bull shark cage from the startup company, we looked at it and thought that it should be developed. So Ken Barra actually is working now with Dr. Abbasi, and he was the engineer who then was at that case and helped me develop the tools and instrumentation for that. And I've personally gone on, we've done a couple thousand interbody cases through Cayman's Triangle in the last 15 years. And we've taught docs all over the country. And Ken, are you available to come on and show some of the progress after that first case and how that developed from then?
Yeah, I'm here.
Did you want to get on and explain that to us?
I, I don't really have any slides to present, but yeah, we can talk a little bit about the development of the system.
Yeah, I think just go over what happened after the first case, where, quickly how you developed the products, what they were. I mean, they're pretty simple products. I mean, we developed simply did we were big on stimulation to try to stay away from the nerve root and make sure the pathway, the orientation approach was such that it didn't tilt down near the nerve root, but what came from under and through the widest part of Cayman's Triangle, and developed the tools to do that. And Ken was very instrumental in doing that for us, and went back and patented it, and had a number of players from that company work with him. And just if you want to say a few words about that, Ken, go ahead, because I think I'm pretty much done.
Certainly, following Dr. Schell Kim's reference, Dr. Schell is the OG of the Trans-Kambin interbody fusion here. I was very fortunate to work with him and several other very talented surgeons that were on the cutting edge of doing minimally invasive surgery. Notably, I'm surprised Dr. Kim didn't mention Dr. Osman. Dr. Saeed Osman did a lot of work with endoscopes for Trans-Kambin. And then Dr. Randy Bishop and Dr. Will Talley, who I know Dr. Abbasi went to visit during his initial exposure to the Trans-Kambin OLLIF. So worked with a lot of those guys.
You're killing me right now. I knew I was going to forget a bunch of people. You're so right. In my own defense, you're totally right.
Well, Saeed Osman is just he's a wonderful guy and a wealth of knowledge and always pushing the boundaries.
Absolutely.
Going back to the development of OLLIF here with Dr. Schell, we've been working on a transfacet screw with Dr. Schell, and that was the reason I was in the OR and spent time with him. And we developed some of those instruments. We took that initial dilator and access portal and started developing discectomy instruments through that and expanded on it. Took inspiration from a lot of things that were used in other ways, found interesting new ways to put big instruments through a small cannula, like especially the flexible curette blade is a nitinol blade that deforms going through an 8mm cannula and reshapes itself into a 16mm curette, which that kind of empowers these kind of procedures, putting expandable devices through small access portals, and then being able to do a very thorough and robust discectomy. And those were all things that I took a lot of inspiration from surgeons like Dr. Schell, Dr. Talley. We worked with Dr. Sahai in Boca Raton. Another endoscopic OG is Dr. Jeff Katzel, who we spent a lot of time working with. And just took all those, developed a couple of implants that started the whole OLLIF process. Had a lot of surgeons coming and visiting and collaborating and working, and it was just a wonderful collaborative experience with training. Surgeons coming to OLLIF cadaver trainings, bringing their experience from other endoscopic procedures. International surgeons, we had a lot of interest from surgeons in Colombia and Mexico and Brazil, and incorporated a lot of wonderful input from all of their different things, going back to the topic of surgeons like in Iran that have great skills but don't have all the same technology available. That was something that we saw. Dr. Schell went with us to Mexico to do some training labs there, and the surgeons were all very capable and ready, but they didn't have the access to that technology. And that was one of the great things that we were able to do with OLLIF, is compact all of this into a very small instrument set that's very concise. It doesn't require lots of extra external pieces to do the surgery. And that was one of the key driving factors from all the surgeons we worked with, was to keep it simple, not make it all complicated, find the least number of instruments, combine the steps so that we're not adding complexity, so that we're keeping it as simple and maintain that minimally invasive approach. And that led from the origins there to working with Dr. Abbasi and advancing that through the last 6 years at Advanced Research Medical, Inspired Spine, and all the great work that he's been doing to evangelize the OLLIF approach.
Well, thanks, Ken. I just want to finish by saying that it takes a real organized team to really build on this, and I think this is a new chapter for this procedure. I think the Kambin approach is really the key, and it's good people that are here today that hopefully can bring the team back and start promoting this because it's something that is not costly, can be done outpatient, much safer than the much larger procedures. And old guys like me can do maybe not as many cases as Dr. Bassi, but we're still pretty active and able to keep going. So I think it's a wonderful procedure. And thank you for having me. I appreciate being part of this.